All right, today we're going to talk about psychosis, and this is one of the most anxiety-provoking areas for psychiatric providers in general. So what we want to do is go through the diagnostic reasoning for psychosis, and the goal is to make this very clinically usable, not just theoretical. So what I want you to learn is how to think when confronted with somebody who manifests symptoms of hallucinations and delusions and disorganization. And also, I'm going to pay a little bit of tribute to some things that mimic psychosis or underlying medical conditions that can cause it. I uploaded a separate video for you on the anti-NMDAR encephalitis, which is one of the more common medical reversible causes that can manifest with psychosis. So I'm not going to spend a lot of time on that in this lecture. But by the end of this lecture, I want you to feel reasonably confident doing three things. So first, I want you to be able to diagnose psychosis accurately with the mental status exam and the DSM-5 criteria. The other thing I want you to be able to do is to map the symptoms you're seeing to the RDoC domains so that your treatment plan isn't just random, but it's circuit-based. Because remember, medication is one of the primary treatments for psychosis, but we need a neurobiological theory as to why we're prescribing the meds we're prescribing. And then the third thing I want you to do is make sure that you are very systematic in your diagnostic process so that you are clearly distinguishing a substance-induced psychosis from a primary psychosis or somebody that's malingering, because that also tends to be popular. So these three skills are what will elevate you from just doing like checklist psychiatry on an algorithm according to the DSM to being able to truly clinically reason through this diagnosis. Okay. So let's start with a little case here just to kind of get our minds focused on something a little real. So a 26-year-old man is brought from jail for a psychiatric evaluation. And he's convinced that the correction officers are whispering about him and that there's a camera embedded in his tooth. Now, here's what we need to immediately grab your attention, right? So what he's demonstrating is some paranoia with a surveillance theme. Also, the sleep is down to 2 hours. There's a history of daily cannabis use and also some guarded scanning behavior. And on exam, you'll find that the speech is pressured. There's a constricted affect and some intermittent responding to internal stimuli. And already your differential should include primary psychosis, but also cannabis-induced psychosis. And he's on his way to jail, so malingering could also be a factor because of the jail setting and the external incentives that may exist. Now, you don't know until you are systematic in your approach. So the next step is classic collateral from who? Well, from the custody officer, right? You want to find out from them what exactly is the situation. And what you're looking for is consistency of the symptoms across multiple encounters, because that's the kind of thing that you will see in psychosis. Okay, there needs to be consistency. It can't just be I'm psychotic on the way to jail. It needs to be I'm psychotic before jail, on the way to jail, and in the jail, right? It needs to be consistent. So psychosis evaluation needs to become almost a ritual for you. And the ritual needs to be something like always focus on safety. You want to make sure you always consider suicidality and homicidality. You need to contend with agitation, delirium, and any acute physiologic changes. So the anchor to your entire evaluation is going to be the mental status exam. After that, you're going to develop a structured differential process that makes sure you rule out substance-induced condition, underlying medical condition, and then a primary psychiatric disorder, mood disorder with psychosis. And one of the main things you want to elicit as you go through this is the duration, because you will have noticed that the DSM makes distinctions of the diagnosis based on how long the symptoms have been present, right? So you're going from brief psychotic episode to schizophreniform to schizophrenia, right? Less than 30 days, from 30 days to 159 days, and then, or 180 days, and then, over 6 months, you get schizophrenia. So that timeline is very important to making a definitive diagnosis. And if the story feels inconsistent or theatrical to you, then you want to know about some validated tools you can use, like the SIRS-2 or the MFAST. You can Google them and run them through AI to get an idea. These are not diagnostic tools. These are just designed to confirm index of suspicion and to provide sufficient structure, because if you say that there's malingering, you're going to have to substantiate that in the legal system as well. So it will be helpful if you have ways to corroborate. And that's going to be also important if you ever get called to do, like, what was their mental state at the time when they committed the crime? And do their mental state holding up now that they can participate in their defense? So those are some of the tools that are used to substantiate your assessment. That, in addition to the capacity evaluation I talked to you previously about. So this structure prevents you from getting lost in the narrative. You can get overwhelmed by the story, and this is designed to help bring some organization. So let's ground ourselves here in the mental status exam. This is the backbone of diagnosing psychosis. And what you want to notice is how this slide breaks the mental status exam into purpose and core domains. So first, you want to organize your observations and anchor your diagnostic reasoning. And you want to link every finding to safety, function, and the differentials. And then the other thing you want to do is you want a good enough exam where you are creating a baseline that you can then return to over time, because this is your point of reference at subsequent visits. So your future self or the next clinician is going to rely heavily on how clearly you describe this first encounter. So on the right side here, you see these 8 core, on the bottom, core domains there. And getting a call. So you see these 8 core domains, and these are not random categories. They're the scaffolding of the assessment. So you see things like appearance, behavior, speech, mood, affect, thought content, perception. And then you're going to see also things like cognition, insight, and judgment. In psychosis, abnormalities in just 2 or 3 of these domains can completely shift your differential diagnosis. So think of the mental status exam as the neurological exam of psychiatry. So if you do it well, then the diagnosis can become quite clear. All right, so let's break down the mental status exam. In the first upper quadrant there, this is where you gather your earliest clues, right? This is before the patient even says a word. Under appearance, you're looking at grooming, hygiene, clothes, posture, and overall presentation. So a disheveled patient may suggest negative symptoms of depression, but if they're bizarre or seasonally incongruent, dress might lean you towards, say, schizophrenia spectrum illness or mania. And then behavior, this tells you about their internal state. Are they agitated? Are they guarded? Do they avoid eye contact? This is where you might elicit what we call catatonia. It lives in this behavioral domain. So do stereotypies, odd mannerisms, that's the classic finding of psychosis, that responding to internal stimuli. And then on the right side there, you see speech, and speech gives you a quick window into their thought tempo. So pressured speech hints at mania. Slowed speech can be depression or an extrapyramidal side effect. And quantity matters too. So if there's poverty of speech, well, that's a negative symptom, whereas verbosity may reflect disorganization. Finally, take a look there at the mood affect. Mood is what they report. Affect is what you observe. So if the mood and affect don't line up, that is to say they are incongruent, say when a patient says they're fine, but they're looking terrified or flat, that incongruence can be diagnostically meaningful because this entire thing is really about how you are articulating your first impression. And that's what actually matters. So a lot of the exam is being done passively observed before they even answer a question. Now, this slide here is the heart of psychosis. This captures what the problem is. So it is a thought process. Psychosis is a thought disorder. This is the form of thinking, not the content. So what you're looking for here in the process is, are they linear? Are they circumstantial? When you see, say, tangentially, derailment, looseness of associations, the disorganization will point you towards either psychosis or mania. If you see things like, say, flight of ideas, it's rapid but still superficially connected. Whereas incoherence or a true word salad, that tells you that this is very severe. So remember things like neologisms or clanging associations. These are red flags for a formal thought disorder. Now that's process. The next section to look at is content. And here in content, we're talking about themes. Are they having delusions like persecutory, grandiose, erotomaniac, somatic delusions, jealousy delusions? This is also where you will assess for suicidal or homicidal ideations. It's documented under thought content. This is where you want to note ideas of reference or and don't forget this triad in evaluating the severity of the delusion. So when you want to give mild, moderate, severe, the three things that help you distinguish that is the level of conviction, the level of preoccupation, and how rigid or lacking that insight is. How fixed is it? These things, the conviction, preoccupation, and level of insight, are what help you determine risk and functional impairment more than what the contents of the delusion is. And then finally, there's this thing called perception. And perception, essentially, you want to clearly characterize what kind of perceptual disturbance you're seeing. Which modality is the problem, right? Are the voices inside or outside their head? Is it just a running commentary on what they're doing? Or is it some sort of command auditory hallucination that tells them to do something? Is it intermittent or continuous? And are there identifiable triggers? What I have found in my long-term chronic schizoaffective types, even though they've been stable for a long time, what I will find is sometimes they will get very bored and not have a lot of purpose and stuff to do. And then the voices will come back. And you'll ask them, are you bothered by this? And they'll say, no, I don't mind them. They kind of keep me company. So those are ones you may not want to aggressively go after because they understand the trigger and they get a little benefit from it. So that's different than, say, something where it says, you must cut your wrist. No one will love you unless you do this horrible thing. That's a lot different. So what you want to do is you want to also clearly differentiate a hallucination from an illusion. These are not just semantical differences, they're major differences. So a hallucination is so an illusion is a misinterpretation of a real stimuli. Whereas a hallucination is the perception of the stimuli, but it's not really there. And so you may have things like depersonalization, derealization. This is where the perceptual the distortions are occurring. Just because they're having depersonalization and derealization, that does not equal psychosis. That's that is to say how they are understanding or interpreting their current circumstance. So this slide is broad. These are like board style questions where they love to hide things in here. So what we're looking for here is what looks like real life. And this is where the diagnosis can be articulated. So now we're going to go on here and we're going to look at the other parts of the mental status exam, specifically cognition, insight, and judgment. Now, these are the domains that help you determine safety, capacity, and treatment trajectory. So these things matter a lot because this is the stuff that they're really asking you when they have you evaluate a patient. Everyone wants to know, how safe is this patient? What is their risk level? And all you have are the questions you ask and the collateral you can get to confirm what you're hearing from the patient. So cognition begins with these basics. Basically, cognition starts with orientation, attention, and working memory. This can be assessed with something as simple as digits backwards or serial sevens to give you a snapshot of their mental organization. Now, if they've never been good with math, they may not be able to do serial 7 beyond 100 minus 7 is 93, and beyond that they can't do anymore. So you're going to have to find another way to do that because they may have a math deficit. And this will change generationally because other things we look at for abstraction would be things like proverbs. A stitch in time saves nine means something to my grandmother, your grandmother, but to a modern person, a stitch in time saves nine will have no idea what that means. So you're going to have to find some modern day proverbs so that you can test level of abstraction. And then the other thing you're looking for is executive control, right? So how much are they at planning? So if they can explain their thought content and what they need to do, or if they need to count on their fingers to do serial sevens, that's all fine. What you're seeing is the organization before you of how they're going to solve the problem. And that's all very reassuring. The other thing you want to pay attention to in terms of cognition is you want to figure out how flexible they are or how rigid the thinking is. In psychosis, you'll often see concreteness and difficulty shifting mental states. They can't move with the conversation. They don't get social cues. They may not get humor. They may not get pun or innuendo. So you got to be really careful using that in somebody with psychosis. The other thing to take a note of is insight. So insight is not binary. You're not asking, does the patient recognize that something is wrong? Do they connect it to their experience as an illness? And are they open to treatment? Right? That's what you're asking. It's not, do they just realize it's wrong? It needs to be connected. So that insight is treading all over that capacity criteria we previously talked about. So poor insight is the hallmark of schizophrenia spectrum disorders, and it strongly predicts relapse and medication non-adherence. Why might it do that? Because I'm not sick. I don't need that medicine. Therefore, I'm not taking it. So that's a major predictor. That's going to be maybe your long-acting injectable patient. And finally, judgment. Judgment is where safety lives. So can the patient realistically appraise risk? Do they anticipate consequences? Can they make decisions and follow through on basic plans? Someone can be oriented and articulate, yet still have profoundly impaired judgment because their delusional system is dominating their decision making. So when you evaluate these domains, you need to think cognition tells me, can they think? Insight tells me what they think about their thinking. And then judgment is going to tell you how safely they are to act on their thinking. So our working definition of psychosis can be distilled into something usable in clinical practice here, right? Psychosis is impaired reality testing. And that impairment shows up through disorganized behavior, plus one or more of the three big three. Three what? Delusions, hallucinations, disorganized speech. So delusions, fixed, false beliefs, despite evidence to the contrary. That is the definition of a delusion. A fixed belief despite evidence to the contrary. In DSM-5, a carve-out was made for gender. In DSM-4, there was gender dysphoria, you weren't happy with it, but if you truly believed yourself to be of another gender, in DSM-4, that was a delusion. In DSM-5, they said that's not a delusion. We've carved out gender from the delusional criteria. Hallucinations is perceptions without an external stimuli. So to be a hallucination, just think of the five senses. If something is occurring in one of the five senses, but not really, that's a hallucination. And then disorganized speech, that's where you'll see the evidence of how they can think. And remember, schizophrenia is a thought disorder. So you'll see derailment, tangentiality, incoherence, disorganized speech. That's especially important because it's the most observable indicator of thought disorganization. So notice what's not on the list. What's not on the list are things like negative symptoms, catatonia, bizarre behavior. Those are associated features. But the core triad is what establishes psychosis. So when you're working, say, in an emergency room or a mobile crisis team or a jail setting, or even in primary care, the fastest way to anchor your decision making is to simply ask, is this person accurately perceiving reality? And if not, which of the big three is driving the distortion? Is it the delusion, hallucination, or disorganized speech? Everything else, diagnosis, safety planning, medication selection, all that becomes clearer once you can say which of these three is really driving that impaired reality testing. All right, so let's get specific about delusions because the quality and structure of the delusion will tell you far more than the theme itself. So a delusion is a fixed false belief held with conviction, resistant to logic or evidence, and not better explained by a cultural or subcultural norm. All right. So if it's something that exists in the culture, like the evil eye, or cold is really bad for health, or whatever exists in those cultures, we wouldn't call those delusions. Those are cultural and subcultural norms. So you just they're not detached from their reality. When you're assessing delusions, what you want to do is rate these key dimensions. You want to rate the conviction. Conviction is how certain are they about this thing? You also want to rate the preoccupation. How much mental real estate is this occupying for them? And then the level of distress. Are they suffering because of it? And then what is the behavioral impact? Does this delusion change how they act? These are the four dimensions that tell you severity, risk, and urgency. The next thing you want to ask about and inquire is bizarreness. So bizarreness refers to the physically impossible belief. For example, the FBI removed my organs and replaced them with plastic. Okay, that would be a bizarre delusion. Versus a plausible but false belief. My neighbor is recording me through the wall. It's plausible, but still false. And then bizarre delusions tend to correlate with primary psychotic disorders and more severe thought disorganization. So there are several types here. You can see the major types of delusions on the right side of your screen there. The most common across all settings is persecutory delusions. They're out to get me, they're following me, they're spying on me. That's the most common. Grandiose, that's an inflated power or special identity. So I had a patient that said, I cannot pee, I will not pee, because if I pee, I will flood the world. And the man proceeded to not pee for over 20 hours. Well, what did that do? Put him in post-renal failure because the bladder was backing up. So he needed a straight cath because his grandiose delusion was blocking that situation. And he was in a lot of pain in the leg. An erotomaniac delusion, this is the belief that someone of a higher status is in love with them. Okay, so that is pretty interesting to note. You may find that also to accompany some narcissism as well. You can see that in sometimes grandiosity associated with bipolar. And then the somatic delusion, this is a false belief about a bodily function or illness. So my teenager who had cannabinoid-induced psychosis was convinced that he had a cancer in his body that was eating him from the inside out. And he would cry about it, and he would tell his mother, "I'm so sorry, I'm dying." But it was really the cannabis was too high, and so he went on antipsychotics, stopped the cannabis, and eventually, in the course of 2 weeks, when you said, "What happened to the cancer?" I guess that was wrong. Yeah, okay, good. So that kind of faded. But the point is, even substance-induced conditions can cause some of these delusions to form. Another delusion is jealousy. This is the jealous delusion about partner infidelity without justification. Now, that justification could be projection from a previous relationship, but if it's not actively currently going on, it is a jealous delusion. And you can, of course, have mixed and unspecified. These are multiple themes with unclear structure. Um, the theme does not diagnose the disorder. It's the structure and severity that diagnose the disorder. So a persecutory delusion in major depression with psychotic features looks very different from one, say, in schizophrenia or a substance-induced psychosis. So that's why we need to evaluate intensity, the conviction, and the behavioral consequence, not just the content. So this slide is pretty important in terms of diagnosing psychosis. So there is something called the passivity phenomena. This is also known as thought interference. And these are classic first-rank symptoms. And when you hear them, your diagnostic radar should immediately lean towards schizophrenia spectrum illness. So the first one we want to talk about here is this core experience of thought broadcasting. And this is the belief that others can hear your thoughts. This is not one of those, did I just say that out loud situations? Okay, because we all have that kind of thing. And then the other one is thought insertion. Thought insertion is the belief that an external force put the thought into your mind. And then thought withdrawal, this is the belief that thoughts are being taken away. These experiences are not just delusional themes. They reflect this loss of the sense of agency over your own mind or the patient's mind. This clinically is called the passivity phenomena, and this often appears alongside persecutory or control delusions. Someone is influencing me, someone is controlling my mind. This is not OCD. There's a distinction. In OCD, the intrusive thoughts are ego dystonic, but the patient still knows that the thoughts originate from their own mind. With passivity phenomena, the ownership is gone. So when a patient describes these experiences, you need to recognize that you're hearing true primary psychosis, not anxiety or trauma or intrusive thinking. All right, let's move on to hallucinations. So this is another core feature of psychosis. Hallucinations are perceptions without external stimuli. So that's what distinguishes them from illusions, which are misinterpretations of real sensory input. Also, note the difference from a hypnagogic or hypnopompic experience. These happen at sleep-wake transitions, and they're not considered psychopathology. So if the person is only having them at sleep-wake transition times, we wouldn't want to call that a perceptual disturbance or hallucination. So the modalities matter because they guide your differentials also. So auditory is the most common form in schizophrenia. Visual or tactile hallucinations need to make you think about delirium or substance use. If you're having olfactory, that is smell, or gustatory, which is taste hallucinations, that should trigger you to think about something like temporal lobe epilepsy or some other neurologic condition. So when you assess, you want details. What is the content? Where is the voice or stimulus located? Is it inside the head or outside the head? How often does this occur? What triggers it? How much distress does this cause? Do they feel in control or overwhelmed? And always assess for command hallucinations, because the content and the patient's ability to resist the command is the essential component in safety planning. They may bring themselves to the hospital knowing that they can't resist these, and they have done this before, and that's a good protective factor to keep in mind, that they bring themselves to care and they recognize their limitations. All right, let's drill a little deeper into these auditory hallucinations, because this is the most studied and the most relevant modality in terms of psychosis. So, genuine auditory hallucinations often have a few consistent features. First, they're perceived as external voices. Frequently, it's something in the second or third person. Second, they tend to be intermittent, with intensity that fluctuates throughout the day. And third, the content is often critical of the person, derogatory, or a running commentary on what they're doing. So, you're not good, are you? You're terrible. You can do a YouTube video search for auditory hallucinations, put on the headphones and try to take a mental status exam. Very freaky, but it'll help you simulate what an auditory hallucination may sound like. Occasionally, they may ask questions, but a crucial thing to keep in mind is that true hallucinations almost never provide novel information the patient could not generate themselves. True hallucinations almost never provide new information that the patient could not generate themselves. On the right here, your clinical anchors. Take a look at this. Onset and course. Is this first episode versus chronic? What precipitated it? And how often does this occur? And then you want to dig into source and location. Is it inside the head or outside? Is it one voice or multiple? Is it familiar, a male, a female, a child? And then you want to look at control and coping. Can they ignore it? Do they try distraction strategies? And then the big one, of course, is always insight and risk. Do they recognize the voices as a symptom? And if commands are present, then what exactly is the voice telling them to do? And do they feel compelled to obey it? And have they ever acted on the commands before? Because these questions are going to help you differentiate mild psychosis from an intermittent safety concern. Intermittent versus imminent if it's ongoing or consistent. And how dangerous is this now? So this slide kind of gives you the overview as to if someone says, I'm hearing voices, this is the kind of questioning you want to pursue. All right, so now let's move on to the non-auditory hallucinations. These matter because they shift your differential. So visual hallucinations, especially if they're having formed images like people, animals, geometric patterns, these are far more common in things like delirium or Lewy body dementia, Parkinson's disease, or a substance-induced condition, rather than you'll see this in primary schizophrenia. So if a patient tells you they see shadow people or trails, this is supposed to alert you to a possible toxic metabolic or neurological process. Tactile hallucinations like formication, bugs crawling, these are classic in stimulant use disorders, especially cocaine and methamphetamine, and also in alcohol or benzodiazepine withdrawal. So that's when you might notice tactile. They also might try to pick at things that aren't there in the withdrawal state. Olfactory hallucinations, these are things like they smell like burning, they smell poop, they may smell metal. These things should really prompt you to look for a temporal lobe epilepsy, or head imaging may show an intracranial lesion or migraine. This could be a migraine aura. These are rarely psychiatric in nature, so you want to pay attention to, you don't want to miss an underlying medical condition. Gustatory hallucinations, they may say, I taste things like metal in my mouth or bitter tastes with no stimulus. These are pretty uncommon, and usually these two are neurological or metabolic in nature. So that should definitely prompt a more direct investigation. So auditory, think primary psychosis. Anything else, visual, tactile, olfactory, gustatory, you want to think substances, delirium, or something neurological. If non-auditory hallucinations are present, you need to broaden your evaluation beyond psychiatric. Okay, so this slide here is going to summarize for you some core features of formal thought disorders. And one of the most diagnostically most powerful parts is of the mental status exam. So derailment, this is, or loose associations, is when the patient shifts between ideas with weak or illogical connections. And the goal of speech is lost when they're derailed, meaning what is the point of what it is you're trying to say? Gone. That's derailment. Tangentiality versus circumstantiality often confuses people. So the distinction is this: tangential speech goes off track and never returns to the question, whereas circumstantial speech comes back to the question with a detour and some excessive details, but they eventually will get back to the main point. Incoherence or word salad, this reflects unconnected or ungrammatical phrases with no inferable meaning. And this is fairly severe if you're seeing this. Whereas neologisms, these things are made up words and they can clang associations. Speech is driven by sound or rhyme, and these things signal deeper disorganization. And then these three, you have perseveration, echolalia, and thought blocking. So perseveration is this repetition without purpose. And echolalia is echoing the interviewer. They'll just repeat back the last few words said. Thought blocking is that sudden interruption where the patient just stops mid-sentence because the thought simply evaporates. Now, that can happen in high-stress situations. That can happen when you have a lot going on. That can happen at certain stages of life where, when you're older and suddenly the pause is no longer for effect, but you've utterly forgotten what you're saying. So that in of itself does not make the person psychotic. And then the critical takeaway is that disorganized speech isn't just a symptom. This has a functional consequence. Disorganized speech will impair things like communication, decision-making, adherence, and safety. So if a patient cannot follow a treatment plan, if their thinking can't maintain a coherent thread, they're not going to be able to engage in good outpatient treatment. All right, so now we're going to talk about the lifespan of psychosis across these transdiagnostic categories here. So let's start with these positive symptoms. These are excess or distortions of normal function. So positive symptoms are hallucinations and delusions and disorganized thought and disorganized behavior. Neurobiologically, these positive symptoms are thought to come from the mesolimbic dopamine hyperactivity. And that's why things like D2 blockade with antipsychotics reduces them so effectively. Think of persecutory delusions or command hallucinations. These are the quintessential positive symptoms. The other side are the negative symptoms. That's the dimension that's truly driving disability, because people with pervasive negative symptoms will often not come to care because they're not bothering anybody. And these typically involve a diminution of normal function. You'll have things like the 4 A's: avolition, anhedonia, alogia, asociality. They'll also have apathy or a reduction in emotional expression. So these symptoms are thought to map onto the mesocortical dopamine hypoactivity, which is why negative symptoms tend to respond so poorly to traditional antipsychotics. So this is the domain of psychosocial rehab, structured routines, behavioral activation, cognitive remediation. Those things will matter much more here than medication. So in general, it's the positive symptoms that bring patients into the hospital and then they get care. Negative symptoms will keep them from returning to baseline after they're discharged, and they may not come to care. So it's important to recognize both. So negative symptoms here, avolition is a reduced initiation of goal-directed activity. And these are the patients that are missing ADLs and they're not showering, they're not paying bills, they're not following through, not because they're oppositional, but because the drive system is offline, essentially. Anhedonia here is specifically anticipatory anhedonia. So this is the inability to look forward to pleasure. This is different from depression, where both anticipatory and consummatory, meaning the pleasure for here and now, is gone. So they're not enjoying here and now, and they can't anticipate pleasure in the future. That's the anhedonia of depression, whereas the anhedonia in psychosis is more about the future. Nothing will be pleasant then. They're not really bothered with now. Diminished emotional expression. This involves that flat or blunted affect and reduced prosody, which is the rate, rhythm, speed, and quality of speech, volume. And also you'll notice reduced gesturing. This is not about feeling nothing. This is like alexithymia, where there's a difficulty in expressing and feeling what's being felt. Alexithymia and alogia are often difficulty in identifying emotions, and then that manifests as poverty of speech and reduced spontaneity. So that makes engagement with psychotherapy pretty challenging. The other thing about the apathy and the social withdrawal, these often get misinterpreted as non-adherence or a lack of motivation, but in reality, it's the core negative symptom and often the predictor of a poor long-term outcome. So when you see all these symptoms together, you're looking at the part of the schizophrenia that's driving the thing that makes them disabled. Antipsychotics are not going to fix this. Ideally, rehab and structure and psychosocial interventions are going to be essential to go along with this. So this is one of the most practical slides because what it does is it gives you that duration-based framework. So when you're diagnosing psychotic disorders, your first job is not to choose a label, but it's to establish a duration. So duration determines the diagnosis. So step one, confirm the psychosis. You need one or more of delusions, hallucinations, or disorganized speech. Catatonia or negative symptoms can support it, but they're not required. And then step two, what is the timeline? Is this prodromal? Is it active? Is it residual? And what's the functional impact? So once you establish those things, now you have what is called psychosis. Step three will say if it's less than a month, we're calling that a brief psychotic disorder with full return to baseline. Step four is if you have it 1 to 6 months, we're going to call that schizophreniform disorder. And this looks like schizophrenia, but without the required functional decline. And then step five, if you have it more than 6 months, we're going to call this schizophrenia. And the signs and symptoms for 6 months need to persist, including 1 month of active phase of treatment. So that's basically what you're going to do to make this diagnosis. And then step six is the branch checks. If the mood symptoms dominate, psychosis only occurs during mood episodes, then maybe this is schizoaffective or a mood disorder with psychotic features. However, if delusions are the only symptom and functioning is relatively intact, then you could just call this a delusional disorder. Or if substances and medical causes are involved, Then it would be substance-induced or withdrawal, or medically induced, like in the anti-NMDAR encephalitis. So this is the framework that's designed to help you not make diagnostic mistakes, because if you mislabel somebody with schizophrenia, it's really hard to unstick that label. So you really want to make sure by timeline and underlying conditions and level of impairment and that sort of thing to make sure that the diagnosis is right. All right, so now let's take a look at the DSM-5 criteria for schizophrenia. So on the left is the group A core symptoms. You need 2 of these for a significant portion of 1 month, and one of the 2 must be delusions, hallucinations, or disorganized speech. And then there are 5 possible symptoms, which include delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms. And then on the right side there, what you have is the course, impairment, and exclusion criteria that finalizes the diagnosis. So there must be a functional decline in work, relationships, or self-care. And the duration must be 6 months of continuous signs, including at least 1 month of active phase symptoms. And you have to exclude schizoaffective disorder, mood disorders with psychotic features, substance and medical conditions. And this is the subtle but important point. So in people with autism spectrum disorder or communication disorders, you only diagnose schizophrenia if there are clear delusions or hallucinations for at least 1 month. This is the criteria to help you prevent overdiagnosis and to ensure that schizophrenia remains the diagnosis with both symptomatic and functional thresholds. So schizoaffective disorder is one of the most misdiagnosed conditions in psychiatry. So the idea here is I want to sharpen some of your precision as best we can. So you want to start with the first line. There must be an uninterrupted period of illness where a major mood episode occurs concurrently with this criteria A symptoms of schizophrenia. So a major mood episode means either a major depressive episode or a manic episode, nothing else. Next is the key distinguishing feature, and there has to be at least 2 weeks of delusions or hallucinations in the absence of prominent mood symptoms. This is what separates schizoaffective disorder from mood disorders with psychotic features. In mood disorders with psychosis, the psychosis only appears during the mood episode. In schizoaffective disorder, the psychosis has a life of its own. It persists even when the mood symptoms have remitted. And then mood symptoms must be present for the majority of the illness, and that includes active and residual phases. And obviously, for any condition, you have to rule out substance and medical induced. And when you diagnose schizoaffective disorder, you should specify bipolar type or depressive type. And always assess the degree of functional impairment. If you are clinically unsure whether the schizophrenia with mood symptoms or schizoaffective disorder or schizophrenia or which one to pick, schizophrenia is always almost the most accurate diagnosis because schizoaffective is considered the rarest of the 3. The 3 what? Schizophrenia, schizoaffective, and mood disorder with psychosis. Schizoaffective is the least common. So delusional disorder, this is often overlooked, but a critical diagnosis to make in outpatient psychiatry especially. So what you do here is you start with the core criteria. 1 or more delusions for at least 1 month. And then criteria A for schizophrenia can never be met. That means that the hallucinations are either absent or not prominent. And if the hallucinations are present, they need to be tightly tied to the delusional theme. So no disorganized speech, no negative symptoms, no loss of function. That brings you to the defining clinical feature. And also function is not markedly impaired, and the behavior is not bizarre outside the delusional context. So these patients can hold a job, maintain relationships, present as entirely organized until you step onto the delusional topic. You can even elect this person into high office, and mood episodes can occur in brief relative to the duration of the delusional period. Now, the thing about this is you always obviously have to rule out substance, medications, medical causes. Delusional disorder patients are often far more functional and far more subtle than schizophrenia spectrum patients. So you diagnose this by what is not present as much as by what is present. Now, you may call, so we would not necessarily call denial a delusion, because denial is ego protective and it's a defense mechanism because the person cannot contend with reality. But you can see that if the denial lasts longer than a month, then we could probably call it a delusional disorder. All right, now let's take a look here at the duration-driven diagnosis. Susan.
Are oops. Um, are antipsychotics effective in delusional disorder?
No, but they're given anyway.
Yeah. Okay.
No. All right. So let's look at the duration-driven diagnosis within the schizophrenia spectrum. So brief psychotic disorder lasts at least 1 day, but less than 1 month. And you only need one psychotic symptom. So delusions, hallucinations, disorganized speech, disorganized behavior, or catatonia, only one. And the defining feature in brief psychotic episode is that full return to premorbid baseline within that 1 month. And these are often linked to identifiable stressors, including things like postpartum onset. On the right side, you see schizophreniform disorder, and that's the 1 to 6 month window, and it meets criteria A, symptoms for schizophrenia, but the functional decline is not required. And some patients will remit fully, and others, well, they'll progress to schizophrenia. Why that matters is because early assessment and treatment is supposed to dramatically improve the outcome. So think of these diagnoses as time-bound stages. Your job is to accurately place the patient in the right stage so treatment and prognosis can align with the natural course of the illness. And maybe it will resolve and they don't have to be on antipsychotics forever if it's a brief psychotic episode versus a schizophreniform. So this slide here is designed to bring the worlds of clinical diagnosis and neurobiology together because the pills only work on biological symptoms. So we need a neurobiological theory to anchor the pills that we're going to prescribe. So on the left here, sorry, on the top rather, you have the DSM criteria, categorical system. Well, the DSM doesn't tell us why symptoms occur, but it does give you some operational criteria that will help improve readability and communication and documentation across paths. And then you'll see underneath the DSM there, you see the RDoC dimensional and mechanistic framework there. And that's organized around the 6 domains of negative, positive, valence, cognitive, social, arousal, regulatory, and sensory motor. So RDoC is nice because it's said to be transdiagnostic. So it's trying to link behavior to circuits, which makes this really useful when you're trying to understand why two patients with the same DSM diagnosis may look completely different in real life. So in practice, you need to be familiar with both of these. The DSM gives you the billable diagnosis and the shared language to talk to other healthcare providers. The RDoC is going to give you the why do they have this or act this way. That's the mechanism and also will help you identify the treatment targets. So things like cognitive remediation, circadian rhythm work, social skills training. The real power comes from diagnosing with the DSM, but mapping the symptoms to the RDoC domains to guide you towards more tailored interventions. Now, let me just do a little bit on the pathophysiology of this. So, there is a neurobiological model for psychosis. It's the dopamine dysregulation and glutamate hypofunction theory. So, the dopamine hypothesis is pathway specific. And if you in 719 Psychopharm, we spend some more time on this. But the mesolimbic hyperactivity is what is responsible for these positive symptoms. They are what? Hallucinations, delusions, and aberrant salience. So mesocortical hypoactivity, that is the thing that's driving the negative symptoms and cognitive impairment. That's why antipsychotics like D2 blockers, they effectively reduce positive symptoms, but don't really do much for negative or cognitive symptoms. There's a second model, which is the glutamate NMDA hypofunction hypothesis. The theory here is reduced NMDA receptor signaling on the GABAergic interneurons lead to disinhibition of cortical and subcortical circuits. This model explains both positive and negative symptoms and fits with the fact that PCP and ketamine can mimic psychosis. In reality, you have both dopamine and glutamate interacting. Blocking D2 dampens the mesolimbic-driven positive symptoms, but it doesn't really correct the mesocortical deficits, so the need for pro-cognitive glutamatergic strategies are necessary. This RDoC mapping ties these mechanisms to domain. So, for example, positive valence, aberrant salience, cognitive systems, working memory and control, arousal regulatory, sleep circadian disruption. This is where that neuroscience is supposed to help shape the care that you're delivering and what you're prescribing. This slide is like the backbone of understanding antipsychotic effects and side effects. So here you have just a grid to look at the mesolimbic pathway. It's the ventral tegmental area to the nucleus accumbens, the amygdala hippocampus. That is responsible for reward, emotional tagging. If you have overactivity, that's going to drive the positive symptoms, and the D2 blockade reduces these symptoms. The mesocortical pathway, this is the ventrotegmental area to the prefrontal cortex. The function there is executive control and affective regulation. Hypoactivity there contributes to the negative and cognitive symptoms. So these are the ones that respond poorly to D2 antagonism. The nigrostriatal pathway, this is the substantia nigra to the striatum. This is the thing that helps with motor planning and control. So when D2 blockade happens, this is where you get the symptoms of EPS, akathisia, dystonia, Parkinsonism, and long-term risk of tardive dyskinesia is because it's the nigrostriatal pathway that's affected. The tuberoinfundibular pathway, this is the hypothalamus to pituitary. This is the thing that controls prolactin inhibition. When we put D2 into the system, the D2 blocker, what happens is that the dose goes up, the prolactin goes up, they get galactorrhea, amenorrhea, gynecomastia, sexual dysfunction. This will come back in psychopharmacology where you will probably have to memorize this for that purpose, but for our purposes, you won't. But this is to give you some familiarity of the neurobiology theories that underpin what we're seeing. So every antipsychotic effect and every side effect can be traced back to one of these four dopamine pathways. So if you understand these pathways, you'll understand the medications. So now let's take a look at these RDoC domains, starting with negative valence systems. So the circuitry of fear, anxiety, and loss. At the core are these three constructs. You have acute threat, that's the fear response. Potential threat, that's anxiety and hypervigilance. And sustained threat and loss, that's the chronic sensitized stress state. So in psychosis, this domain maps directly onto persecutory ideations. They have a heightened threat appraisal system that turns ambiguous events into dangerous ones, and stress sensitization, especially sleep loss, amplifies the aberrant salience. So for assessment, identity triggers and avoidance behaviors, and physiologic arousal, and always distinguish fear-driven reactions from passivity phenomena. So a patient who thinks people are following them is different from a patient who believes their thoughts are being inserted. The intervention-wise, we want to think about things like trauma-informed communication, de-escalation strategies, anxiety reduction, sleep and circadian rhythm stabilization. CBT for psychosis, that problem with me, I mean, that's all the rage and people love to talk about that. My problem with CBT for psychosis is there needs to be sufficient insight and willingness to go along with it. And if they're in utter delusion, if they're utter denial that anything is wrong, I don't see that being as effective. Maybe they'll learn some coping skills from it, but CBT requires a lot of cooperation. But the goal is to help them to reappraise the threat. This domain explains why many patients with psychosis are not just paranoid, they're operating with a threat system stuck on high alert. Positive valence symptoms, this helps you understand things like motivation, reward, learning, goal-directed behaviors, areas that are deeply affected in schizophrenia. And the key constructs here include things like reward valuation and prediction error, how the brain updates expectations from experiences, and when the prediction error signal is off, patients are misjudging reward, effort, consequences, and this is what contributes to that avolition and anhedonia. The approach, motivation, and habit formation are the neural engines behind the starting and sustaining a purposeful activity. This neural substrate is mesolimbic dopamine. This is the ventral tegmental area projecting to the nucleus accumbens and modulating that prefrontal cortex. So what you see here on the right is this clinical application, this anhedonia avolition. This comes from blunted anticipatory reward. And behavioral activation and structured activity, this scheduling becomes a core intervention. You're doing things like contingency management and motivational interviewing to help translate their values into actions. But this requires, again, high degree of insight and cooperation. So pharmacotherapy alone is never going to fix this domain. This has to be paired with reward-based psychosocial approaches. So where you might see this is in long-term inpatient schizophrenic populations. This is where they set up a token economy. There's a unit up at White Plains that has a token economy set up on their long-term schizophrenia. And the goal is to habituate this and to prevent state hospitalization. So cognitive systems domains explains the many deficits that persist even when positive symptoms improve. The key construct here is this notion of attention and vigilance and working memory. Now, cognitive control, this is the set shifting inhibition problem solving. So clinically, these deficits show up as disorganization, concreteness, and impaired planning. So it's important because cognitive deficits persist across all illness phases being prodromal, active, and residual, and are some of the best predictors of long-term functional outcomes. So that means your assessment has to include attention, memory, and executive functioning. So interventions that map directly to those deficits, like cognitive remediation, targeting attention, working memory, control, supported employment, or education programs with task coaching, vocational rehab functions well here, where they give you a coach to go with you to the job to help you to be successful. And environmental scaffolding, so checklists and environmental cues, structured routines. These are the behavioral psychotherapeutic interventions to address these cognitive deficits. These are the things that can get you back to work. These are not side issues. These are central drivers of disability. The social process here gives us a way to understand interpersonal struggles, which are common in psychosis. The key concept here is that social perception, that is reading faces, emotions, intentions, do they have a theory of mind where they can understand others' beliefs and motivations? And also, this looks at things like attachment, affiliation, and communication. So when these circuits are impaired, you're going to see things like misattribution of intent, which may stoke paranoia and ideas of reference, and impaired perspective taking that leads to conflict and social withdrawal and chronic isolation. Think about your homeless person on the street that's having this social processing deficit, right? If he misinterprets, leading to conflict and escalation, this is what generally causes the public disturbance and then involves the police, and then they come to the hospital or go off to jail. Um, on assessment, you want to observe for symptom for are they able to be reciprocal in the nonverbal cues? Are they reading the room? You want to ask patients about how they interpret other people's motives and gather collateral information. Don't just take their word for it on social and role functioning. How do these people interact? Are they having problems across the board? Because the interventions here are going to include things like social skills training with modeling and feedback, family psychoeducation to reduce expressed emotion. This is the person screaming on the street corner. We don't want that. Structured group activities and supported employment or education. These are things to improve this domain, essential. Social functioning is going to be one of the strongest predictors of a real world recovery. And then this is our final RDoc. We'll do this and then we'll take a quick break. So arousal regulatory domain. This is extremely important, but often overlooked as a driver of psychotic symptoms. The core construct here is dealing with the sleep-wake regulation, circadian timing, and autonomic arousal and stress reactivity. So insomnia or fragmented sleep can amplify positive symptoms and sharply increase the risk of relapse. Circadian rhythm misalignment contributes a lot to mood instability, cognitive inefficiency, and daytime irritability. Heightened stress reactivity can increase the perceptual salience of being of benign stimuli. In other words, you will overinterpret something benign. And so what happens is you are essentially priming the system for psychosis, which is why I told you in the beginning, and I repeat to you, the first symptom I go after is this arousal regulatory, that is sleep. I need the sleep consolidated first to make sure there's enough psychological and physiologic reserve to contend with the stressors so that you're not exceptionally irritable, and in the wrong hands, you may buy yourself a diagnosis of psychosis, and we don't want that. So your assessment has to include a full sleep history, circadian rhythm pattern, medication timing, caffeine use, substance use, stimulant use, shift work. Your interventions need to be aligned with the proper domain. You want to get them to establish a regular sleep-wake cycle, morning light exposure, maybe a light box. CBT for insomnia would be good here. Also, don't forget, obstructive sleep apnea can interfere with this, or periodic limb movements like restless leg. Go back to the sleep disorders chapter. They must be ruled out. Because often when you fix sleep and circadian rhythms, many of the symptoms will improve faster than with medication alone. All right, let's take a break. All right, so now we're going to shift gears. Now that we've walked through the symptoms and the pathophysiology and the diagnostics, we're going to zoom out to something more valuable. This is where your history is going to be taken. This 4P formulation, which we've talked about repeatedly in the past. This is where you take everything you've gathered and build this coherent clinical narrative, not just a diagnosis, but why this person, why now, and what keeps this condition going. That's the 4P structure. So predisposing, precipitating, perpetuating, and protective factors. So let me say this again, because this is the formulation for your practice. This is how you are going to basically describe what you're seeing more than just a checklist. What you're trying to figure out is what made them vulnerable, what triggered the episode. Also, what maintains the symptoms and what strengths can you leverage? So what you're trying to do is ask yourself, if I wrote a diagnosis, would I understand the patient? If not, there's a story that you're missing. So this approach keeps you clinically sharp. It makes sure you're doing the trauma-informed care, and it makes sure you're being biopsychosocially grounded. And in psychosis work, especially, this four P's prevents that oversimplification because psychosis almost never emerges from a single cause. This is an intersection of biology, stress, environment, and habits and systems. So let's get into this here. Okay. So let's start with these predisposing factors. So these are the vulnerabilities that increase the baseline risk for developing psychosis. Think of this as the soil the illness grows in. You don't get to choose your vulnerabilities, but they do shape the terrain. So the first category is always going to be genetic loading. So the general population risk for schizophrenia is about 1%. But once you add a family history, that risk starts to climb. Throw in some monozygotic twins, and about 50% concordance occurs. Dizygotic twins, around 15%. That's identical and fraternal for those slow people in the back. Okay, so if both parents are affected, the risk shoots up to about 40%. So this is a polygenic vulnerability, meaning there's no single gene that causes psychosis. It's multiple lower penetrance hits across the genome. And clinically, what does family history tell you? Well, earlier onset, greater recurrence, more severe negative symptoms. So when a patient says, yeah, my uncle had something like this, that is not a throwaway detail. That could be clinically significant unto prognosis. The other thing you want to look at is this issue of neurodevelopmental factors. So prenatal and perinatal insults. Specifically, you'd ask about things like hypoxia at birth, malnutrition, infection, toxic exposures, extreme diets. All of those raise the risk. So when you are seeing a child, there is a reason you have to do a neonatal birth to present day history with mom. Tell me about the pregnancy. How was it complicated? Tell me about the delivery. Tell me about your nutritional status, about your hyperemesis, about the partner, about the toxins, the drugs. All of that factors in. So one thing that a lot of students and even modern clinicians you'll see forget is asking about in utero exposures, especially substances, because that shapes the neurodevelopmental path. Now imagine mom is smoking marijuana every day of the pregnancy, which unfortunately is not uncommon, right? And then the kid also starts smoking marijuana at age 13 or 14, and every single day in escalating doses, nonstop vaping, and they come to see you at 25 years old. That brain has never developed without marijuana on board. Mix in things like recreational other drug use and alcohol, traumatic brain injury, and you really set the stage for some sort of a derailment, essentially. So always ask about prenatal history when you're working with early psychosis patients. We also have some neuroanatomical correlates, not causes, correlates. These are not diagnostic by themselves, but they do have some patterns that can be somewhat consistently seen. Things like enlarged ventricles, cortical thinning, especially the frontal and temporal lobes, smaller hippocampus and amygdala, reduced cerebral blood flow. We don't do head imaging necessarily for psychosis because the problem is doesn't change the management unless of course there's some underlying issue, but you want to have a focal deficit before you go scanning people. Don't randomly scan everybody. The reason this matters is because these findings on scans sometimes will correspond to functional deficits you'll see, like memory issues and affect regulation problems and cognitive slowing. But the fact of the matter is you can still diagnose those things without the imaging results, and it doesn't change the treatment. So predisposing does not mean your destiny. It just means risk, not inevitability. So now we'll move from vulnerability to what actually triggered. Why is this day more special than any other? If predisposing factors are the dry forest, think of precipitating factors as the spark that brought you to care. So it could be things like substance. Substance is one of the biggest ones, especially stimulants, THCs, hallucinogens, ketamine, is popular now in the underworld. These are well documented triggers. Also, alcohol and benzo withdrawal can precipitate psychosis, and boards love to test that combination there. So when we have acute psychosocial stressors like trauma, loss, sleep deprivation, conflict, and sleep is a huge piece here. If you want to trigger psychosis in a vulnerable brain, take away sleep. How many of your patients tell you, I hadn't slept for days right before the episode? The other thing you want to make sure we're listening and looking for are medical and neurological causes like delirium, seizures, steroid use, and anticholinergics in the elderly, especially. Remember, nobody gets first episode psychosis in their 60s or 70s, okay? So pay attention to that. Nobody's getting schizophrenia at 13 years old de novo. Pay attention to those atypical presentations. So does the onset align with a trigger? So psychiatric illnesses rarely explode out of nowhere. That's why I told you we don't really have emergencies in psychiatry. Everything's been brewing for a while until we finally overwhelm our coping protective factor resources, and now we're in care. There's usually a linkage if you look very carefully. Now, the question is, what is it that keeps this thing going? Daily marijuana use. I don't want to give it up. That's a perpetuating factor. Even after the initial spark dies down, these are the winds that keep that flame burning. Another perpetuant factor is things like non-adherence or undertreatment, missed doses, subtherapeutic regimens, poor follow-up. Those are the most common perpetuating factors you're going to see. And again, I can't say this enough. Ongoing substance use, especially cannabis and stimulant use, this creates that pattern of relapse withdrawal, relapse withdrawal. The other big one, of course, is psychosocial instability, homelessness, unemployment, low support. As the illness gets worse, function declines, functional declines leads to worsening illness. You have this negative feedback loop that continues. And comorbidities and cognitive deficits. So someone with schizophrenia can also become depressed. Someone with PTSD can also develop schizophrenia. Anxiety, executive dysfunction, all of these can be leading to what we would call psychotic symptoms, but really those are the underlying things that need to be treated. Those things, depression, PTSD, anxiety, impair executive dysfunction. They impair insight and they interfere with treatment engagement. The other major thing is system factors. What is system factors? Those are fragmented care, ED cycles, frequently back to the ER, not sick enough for admission. Outpatient follow-up is not for 6 months. We don't really give you anything. God bless and goodbye, right? Multiple hospitalizations without continuity, rotating providers, all of those factors. So when you walk into a room with a patient who's had 5 hospitalizations in 1 year, you're looking at a perpetuating ecosystem, not just a diagnosis. Now your job is to change that ecosystem. But money is the major dictator. So let's talk about the part of the clinicians often forget, which is the protective factors. We underrate these. So these are the forces that buffer the illness and predict a better outcome. On the left side there, you'll see some protective factors. Later age of onset is considered a protective factor. A clear precipitant like a trauma or loss or sleep disruption also is a better recovery because the trigger is identifiable and reversible. Rapid access to care is a huge difference. Early intervention programs exist for a reason. Medication adherence, especially with shared decision making, tends to lead to stronger outcomes. Compliance alone is not enough. Shared meaning making is also important. So buy-in and insight are necessary. Because if compliance alone were the issue, you could put them all on long-acting injectables. But obviously, that's not the holy grail. Social support, housing stability, structured daytime activity. You will be amazed to see how much a lack of structure and purpose is affecting the youths of today, and they're buying labels of psychosis, schizophrenia, turning to marijuana and various addictions, essentially. That all of that sets the stage for a high, essentially a bad outcome. So if someone had had a high premorbid level of functioning and education, very protective. If someone had stable work and good relationships and was really high functioning before the illness occurred, that's a really good indicator and predictor of a good long-term outcome. So that's good to know. So high education, structure, environment, support, good things to have. Now take a look at the right side of the screen there. These are the indicators that are poor prognosis indicators. Things like early onset, insidious prodrome, prominent negative symptoms. Negative symptoms are often the big driver of disability. Other poor outcome predictors include comorbid substance use disorder, repeated relapses and non-adherence, limited social supports, low engagement with care. Males tend to do worse, and that's typically associated with more severe symptom burden. And the piece you cannot ignore is these medications tend to cause a cardiometabolic risk. So people with schizophrenia spectrum disorders tend to lose about 20 years of life expectancy. That's not because of the psychosis itself, it's because of the cardiovascular disease and metabolic syndrome and smoking and inactivity and system neglect that accompanies people with a schizophrenia diagnosis. So if you are treating schizophrenia but ignoring metabolic health, are you actually treating the patient? Because the prognosis is not fixed. It's shaped by the biology, the behavior, the environment, and the care you provide. So you can't be myopic. So we can't do a psychosis lecture until we spend some time dealing with malingering, because this is the land of high stakes emergency rooms, jails, inpatient units, and disability evaluations. So anytime the environment offers an external gain, you should at least entertain the possibility of malingering. And the DSM-5 draws a clean line here. So malingering is the intentional symptoms for external incentives, avoiding prosecution, getting housing, securing financial benefits, getting out of jury duty, bringing your dog on the plane, more test time, extra support, tutors, etc. Good external motivations. Whereas factitious, this is on the other hand driven by an internal psychological incentive to be in the sick role. They like nurturance, they like attention. There's no obvious external gain, and this is what makes it diagnostically slippery. So the clinical risk you can't underestimate, because a misclassification of either direction can cause meaningful harm. So you don't want to call it malingering too fast, because then you risk abandoning a patient who is acutely psychotic and medically unstable. And if you miss malingering, then you distort resource allocation and legal decisions and placement outcomes. Take a look here at the prevalence data on the right side. About 30% of disability evaluations raise malingering concerns, and about 29% in personal injury context, and in about 19% in criminal cases. These are not fringe numbers. These are a reminder. The question isn't whether you're going to encounter malingering, it's whether you're going to catch it accurately. So the thing to definitely keep in mind, though, is never label malingering without converging evidence. You have to get collateral. You need to observe function. You do want to use structured tools because the goal is accuracy, not speed. Now, let's talk about this Bruce Rogers foundational framework for identifying feigned psychopathology. So, Rogers' strategies work because they compare a patient's report against known epidemiologic patterns in genuine psychiatric populations. So, let's walk through these categories here. So, first category is rare symptoms. These are symptoms that almost no genuine patient endorses. So, if a patient suddenly has all of them, your antenna should go up. Quasi-rare symptoms are uncommon, but more likely to show up in normative community samples than in clinical samples. So think of these as soft flags. And then improbable or absurd symptoms. This is where physiology and logic fall apart. So impossible sensory phenomena, contradictory timelines, descriptions that violate basic neurobiology. Unlikely symptom combinations is something else to pay attention to. So even if a symptom alone is plausible, certain pairs almost never appear together in real patients. So pattern level detection here becomes crucial. And then spurious patterns of psychopathology. These are the profile signatures. So on structured tools or detailed interviews that simply don't map onto any known clinical disorder. It's like someone checked every box, assuming more equals more believable. So when you see these patterns, slow down and ask yourself, is this presentation coherent and does it track with a known clinical pathway, or is this just a really good performance? So let's move here to the unlikely to amplified. So this is the style of presentation where everything is excessive, theatrical, or too perfectly symptomatic. So for example, indiscriminate symptom endorsement. Patient just checks yes to every symptom across domains without any clinical organization. Or extreme or unbearable severity. Everything is a 10 out of 10 all the time with no fluctuations. Well, real symptoms tend to breathe and they tend to fluctuate. Another thing to raise a red flag is over-endorsed obvious symptoms. So here the patient grabs the most dramatic symptom, but neglects the subtler and more common ones. So it's the difference between someone claiming nonstop, booming, command hallucinations, but forgetting the social withdrawal and the sleep disruption that usually accompanies this decompensation. Reported versus observed discrepancy. So claims of profound impairment that don't match observed behavior. Walking easily, recalling details, interacting normally. Also, erroneous stereotypes of illness, so theatrical, movie style psychosis, the constant voices narrating my every move at full volume type descriptions. That's the stuff that lacks nuance of a real auditory hallucination. What you're looking for here is a mismatch between what they say and what they do and what the literature tells us. So let's look at some actual tools. So there's the SIRS-2. This is the gold standard. This is a structured interview that probes multiple feigning strategies. It looks for rare symptoms, improbable combinations, severity exaggeration, reported versus observed discrepancy. It takes about 30 to 60 minutes to do in forensic settings. This is the backbone of evaluating malingering. You can pull it up online to see it. The other is the MFAS. This is a brief screener of about 25 questions. It won't diagnose malingering, but it does flag possible feigning so you know who needs a full assessment like the SIRS-2. And what you want to do is take a look at the subscales, reported versus observed, extreme symptoms, rare combinations and unusual hallucinations, unusual symptom course, negative image, suggestibility. A positive MFAST, you should know, is not a verdict. None of these tools are diagnostic. It's a signal to you to deepen the investigation and pull more collateral, gather some behavioral observation, maybe escalate to another test like the SIRS-2. Your goal is to eventually have a structured, defensible reasoning because you're not accusing anyone. You're assessing the reliability of the clinical data and You still need to maintain a therapeutic alliance, so you have to do this with curiosity and to let them know that you're looking out for their best interests so you don't put them on medications that can have severe adverse effects and cause harm. So here is a practical six-step approach for malingering and factitious disorder that you can use in real cases. Think of this as like a checklist. So step one, clarify the incentives and context. So start with the environment. Is there a legal case pending? Housing at stake, medication seeking? Your differential changes dramatically depending on the incentive structure. And then step two, you want to look at the collateral records. So this is where the truth usually lives. So you look at things like custody reports, family statements, prior notes, timelines, urine drug screens, anything that gives you an external anchor. Never rely solely on the current interview. And then step three, consistency check. So you want to compare the story across time, settings, and different examiners. So real psychosis is surprisingly stable across contexts, whereas fabricated symptoms shift when details are probed. And then step four, you want to use a validated tool like the MFAST for screening, and then if needed, escalate to the SIRS-2 when you need a forensic grade assessment. If you have access to an MMPI validity scales, or, this is not a bad way to refer to neuropsychology testing for diagnostic clarity. And what that does is it's really building that therapeutic alliance along the way. You're saying, look, I'm not exactly sure. I want to get this right. I'm going to refer you to neuropsych testing. And you wouldn't say rule out malingering, but you would say, look for psychosis, true psychosis, or whatever. And then they can do some more definitive and extensive testing. The other thing is step five, deep phenomenology. You want to anchor yourself in the clinical reality of psychosis. You know when you've seen psychosis. You know the onset, the course, the sensory qualities, the insight, the negative symptoms, and most importantly, you know the associated functional decline. So people can fake voices, but they can't fake true negative symptoms. So that's the phenomenology. That's the whole context coming together. And you want to document cautiously. Always avoid definitive language unless you have converging evidence to support it. You only want to state observations, not accusations. And you always want to reassess over time. Time is often the best diagnostic tool because that's how you're going to stay objective, ethical, and this will wind up in court, so defensible. All right, let's look at some red flags here. These are the tells. These are the patterns that should make you pause. So first, hallucinations with no fluctuation. Genuine auditory hallucinations will wax and wane. They don't run 24/7 like a radio station with zero impact on sleep and functioning. Secondly, absurd and physiologically impossible symptoms. So if someone reports purple elephants walking through the walls all day, or sensory experience that contradicts neurobiology, you're likely outside the realm of true psychosis. And then third, things like maximal severity everywhere. Every symptom is a 10 out of 10. That's not how real psychopathology behaves. There's always variability. So pay attention to that. And then fourth, you want to look at reported versus observed mismatch. So claims of nonstop distress while sitting calmly or sleeping well in the unit or performing tasks that contradict the narrative. And then fifth is this inconsistency across time or examiner. So symptoms that shift when questioned or when a new clinician arrives. And then the other thing is sixth here is this better performance on complex tasks than simple ones. This is a classic malingering pattern. So true cognitive impairment affects simple tasks first. And then seventh is this emphasis on vivid positive symptoms with minimal negative symptoms. So remember, negative symptoms are the anchor of real psychotic disorders. And then the eighth one here is clinically incongruent combinations. So for example, constant external voices, but perfect sleep, perfect affect, and zero distress. So no single tell makes the diagnosis, but if you see a pattern of these things, that's what's arousing your index of suspicion. So malingering is externally driven incentives. You want to avoid like things like what? Avoiding prosecution, obtaining housing, seeking meds. Those are the hallmarks. And you're always comparing reported versus observed discrepancies, improbable or absurd symptoms, clear incentive, shifting or an inconsistent story. The assessment focuses on collateral structured tools like the SIRS-2, the MFAST, Rogers detection strategies that I showed you. And your management is going to be very neutral, structured, and boundary based. You are needing to address the needs and safety, set contingencies, and avoid confrontation. And then, if necessary, you want to consider a forensic consult when appropriate. Forensic is really only if it's involving the law. But neuropsych testing for diagnostic clarification can be helpful. Factitious, this is that internal psychological gain, the sick role. They want nurturance, attention. There's no tangible external reward. And the features include things like dramatic but inconsistent stories, high healthcare utilization, willingness to undergo a lot of tests and procedures, secrecy about prior care. The assessment looks different. Here, you're going to rule out primary illness, review the records, deeply and often involve multiple team members because the trauma and personality factors are frequently underlying this behavior pattern. And the management here requires a non-confrontational stance because if you try to, you're faking, well, that blows up the alliance all of a sudden. So one coordinating clinician is the best step here. So normally what you do here is you put everything through the primary care provider. I tend to inherit a lot of these patients because I do both primary care and psych. So then I can talk to the specialist and I can say things like, why don't we discuss what tests you want to do? And then I will package them and we work alongside because we're all realizing that we're doing a lot of tests and we're stumbling into something and the patient may be harmed. But one coordinating clinician, strong boundaries, and attention to limiting iatrogenic harm, that is harm caused by the healthcare system. And if you remember nothing else, please remember that factitious, they want an outcome in the situation. I'm sorry, reverse that. Factitious wants a role in the situation. Malingering is going after a very specific outcome. Okay, malingering wants an outcome, factitious wants a role. All right, let's get to this because this is highly important in this domain. This is a high yield differential, especially in emergency psychiatric and primary care. So there is a temporal association with the onset and it arises during intoxication or withdrawal or within about a month of cessation. And the crucial part is you have to reevaluate after a period of abstinence. So, because time clarifies the diagnosis. So, for example, a substance specific phenomenology, each substance has a little signature that you can note. So, for example, stimulants, they are prominent with persecutory delusions and tactile hallucinations. Cannabis THC, that's who's going to be paranoid, have perceptual disturbance, and time distortion. Hallucinogens, prominent with them is visual hallucinations, derealizations, and synesthesia. Alcohol and benzodiazepine withdrawal, that's where you'll see visual hallucinations and fluctuating delirium. So knowing the profile helps you separate the drug effects from primary psychosis. And you want to distinguish from primary disorders because if symptoms persist beyond that expected window, or if there's a prior prodrome, negative symptoms, strong family history, then you can start to lean towards a primary psychotic disorder. And so you want to make sure you do good evaluation and follow-up where you create a clear timeline with good collateral, and you want to interpret urine drug screens and detection window limitations. Keep those in mind when you're testing. You want to use serial mental status exams to track changes over time and always coordinate substance use treatment to prevent recurrence. Your goal is to answer one question. Is this psychosis driven by chemistry, by primary illness, or both? And that takes structure and time and a lot of steadiness on your part so that you don't jump to conclusions. Okay, now let's switch to one of the most high yield categories you're going to see in this, and that is that of stimulant use, cocaine, methamphetamine. Stimulant psychosis doesn't tiptoe in. This thing bursts on the scene. Patients will present with things like paranoid and persecutory delusions and intense hypervigilance, and often a level of agitation that feels disproportionate to what you would see in primary psychotic disorders. You're going to notice that the energy in the room is different. This is not someone drifting into psychosis. This is someone locked in fight or flight physiology, and they're here. So cocaine and methamphetamine also will produce for you tactile hallucinations. That's what patients will call like bugs crawling. We call that formication. And you may hear coke bugs in the vernacular. Um, and because this is a sympathetic overdrive picture, always look for autonomic signs like tachycardia, hypertension, dilated pupils. The body is broadcasting the diagnosis even before the patient says a word. The course of this is appropriate because the timeline here is essential. Symptoms typically begin during the intoxication or within an hour of use. And cocaine psychosis may burn out in a few days. Methamphetamine can last days to weeks, even after the drug has cleared. Meth is just simply a different beast. This thing creates a deeper neurotoxic footprint. So if your patient describes a clear temporal link to a binge, escalating use, or multiple consecutive nights awake, that should raise your suspicion for stimulant-induced psychosis over a primary disorder. Now, there are some medical risks. This is where stimulant psychosis becomes a medical emergency, and you always have to consider things like cardiovascular events, MI, arrhythmia, hypertensive crisis, hyperthermia, which can be fatal, rhabdomyolysis, particularly in meth-driven agitation or prolonged struggling. Seizures, especially with cocaine toxicity. These are not benign psychiatric presentations. These are physiologic crises wearing a psychiatric mask. So you have to make sure if you're in a freestanding place, these are 911 transfers to the ER. If they're in inpatient psych, this is rapid response to the ICU stuff. The management for this has two tracks. Obviously, you got to treat the toxic physiology and contain the psychosis. So in these cases, benzodiazepines are first line for the agitation and the sympathomimetic toxicity. You want to think that you want to calm the CNS, calm the cardiovascular system. And then antipsychotics in this situation are PRN. They could be used if the psychosis persists after adequate sedation. Don't reach for antipsychotics first because they can worsen things like hyperthermia and lower the seizure threshold. So you want to provide good supportive care, cooling measures, IV fluids, continuous vital signs. This is an ER or ICU type of patient transfer. So don't forget you're playing the long game here. Every stimulant psychosis presentation, that's like your opportunity to evaluate for substance use disorder, treatment, relapse prevention planning, and the like. Okay. These patients often present in a moment of fear or exhaustion or clarity, and your job is to capitalize on that. The other one we need to talk about, because this is all the rage, it's everywhere, it's in the salad greens, it's in the air, it's in the air freshener, it's everywhere. This is cannabis. Cannabis-induced psychosis typically does not look like classic schizophrenia. This often presents with paranoia and perceptual disturbances, and it's a kind of warped time sense. Minutes feel like hours. The person feels detached from their body. The big clue here is the depersonalization, derealization. Patients feel like I'm not real or the world looks fake. This alone can trigger them to have intense anxiety or panic, which then fuels that psychotic process. Auditory and visual phenomena can occur, but the insight is variable. So some patients know something is wrong, and then others just become overwhelmed and terrified. Now, the risk factors here, there are several red flags to note. High potency THC, that is vape pens and concentrates and edibles, combined with things like heavy use, especially daily use. Adolescent onset, this is the developing brain is simply more vulnerable. And then family history of psychosis, cannabis acts as a stressor on an already sensitized system. And worse, they co-use this with stimulants and sleep deprivation. What stimulants? Well, they're vaping nicotine and nicotine patches in other high doses. So between the marijuana and the high dose nicotine, or God forbid, they start dabbling in cocaine or meth, and they're sleep deprived, and they're in video game world, all of this can dramatically increase the risk when you combine these factors for a perfect storm of cannabinoid-induced psychosis. Timing is important. So symptoms usually come out during the intoxication period or shortly thereafter. And the key message you need to tell patients and families is most cases are going to get better with abstinence. The problem is cannabis can unmask a primary psychotic disorder in an at-risk individual. And now there's some theories that says if you're doing it every day at high doses, some are speculating it may be a cause of. So that's something to pay attention to. So your job is not done after the acute phase. This person you need to bring back and monitor for recurrence in the weeks and months that follow, and especially as the sleep cycle normalizes and hopefully the THC clears after a month or so. Oh, the other thing is we make the mistake, it's stored in the fat. We just assume that it's not psychoactive. It may be. They just used to it at a higher level. So think of this as the person that says to you, oh, I feel fine, I'm just buzzed. You're legally drunk. You may feel just buzzed, or you may feel fine because you have such a high tolerance, but legally you're drunk. And so we don't really have that with THC, and we don't have a way to say, just because it's in the system, you're technically still driving under the influence. It's in there. You may not feel high, but how many people are on the highways? When I was sitting on the FDR Drive, people just smoking a joint, sitting in traffic. I'm like, oh my God. That it's not known to create good reaction time and motivation and insight. So the management with cannabinoid-induced psychosis is calm, low stimulation settings. Treat the severe anxiety with benzos because anxiety itself can amplify the psychotic symptoms. If the psychosis is very distressing or the patient's unsafe, then a short course of antipsychotics is helpful. This is typically what I do. I do prescribe a short course, and then typically these cases don't need them long term. Antipsychotic maintenance, unless you're uncovering a primary psychotic disorder. Abstinence is the key. Psychoed about THC potency and brain vulnerability. And you want to restore the sleep-wake cycle and the circadian rhythm. If you fix sleep, abstinence, stress, most of these patients are going to be just fine. Question is, do they want to fix any of that? Like I told you in the first lecture, no matter how overwhelmed you get, your question is, this is the problem. What is it you're willing to do about it? And that's where you're going to go. So let's talk about LSD and psilocybin. People want to use this to treat everybody for everything. It's a new rage, and even ketamine as well. So these hallucinogens are usually dramatic, and they follow a very predictable pattern once you know what to look for. So phenomenologically, during intoxication, the hallucinogenic intoxication is dominated by visual phenomena. And that's your first big distinguishing feature. So patients will describe geometric or kaleidoscopic patterns, intensified colors, visual trails or tracers. You may hear about synesthesia. Synesthesia is I could hear colors, or I tasted the music. And like cannabis, these substances can trigger a sense of depersonalization and derealization. And that's a profound alteration in time perception as well. So the thing to remember here is the insight is often partially preserved. So the patient may say, I know this isn't real, but it feels real. That partial insight is very different from primary psychosis. Now, the course and complications here, the onset is generally during intoxication or shortly after use, and most symptoms will remit as the drug wears off. But we need to be aware of the longer tail, this HPPD, hallucinogen persisting perception disorder. These are the classic flashbacks that can occur weeks to months later. This is not psychosis. This is more like perceptual intrusions, trailing lights, geometric patterns, intensified colors, and this comes out under stress or fatigue as the trigger. And you want to distinguish this from a primary psychosis because this is where you're going to struggle to make this clean and simple. So hallucinogenic effects are predominantly visual with intact thought forms. You don't usually see the disorganization and derailment and the prominent negative symptoms. And the timeline gives it away. So there's a clear temporal relationship to the substance exposure. So in other words, if the visuals start hours later, LSD or mushrooms, this is not schizophrenia. That's the drug. Acute management is always supportive. You want low stimulant environment, dim lights, calm voices, reassurance. You want to monitor vital signs and hydration. For severe anxiety and panic, benzodiazepines short term are the treatment of choice. Antipsychotics in this case are not first line, and they can actually worsen agitation in some cases. So you want to reserve them only if symptoms are severe, dangerous, or persisting beyond intoxication, which is uncommon. The key thing with hallucinogens is recognizing that the predictable pattern is visually heavy, the thought form is preserved, and the timing is linked to the drug and usually self-limited. So if you can identify that pattern, you get to avoid over-diagnosing psychosis and schizophrenia. Let's talk about alcohol withdrawal. So we shift here into one of the high-risk conditions that you'll see. These high-risk conditions with alcohol withdrawal, specifically delirium tremens. The first thing to keep in mind here is timing is everything. Delirium tremens happens in about 48 to 96 hours after the last drink. That 3 to 4 day window is the danger zone. If someone rolls in and says to you, I stopped drinking yesterday, you're not yet in DT territory, but you need to watch them. And unfortunately, this person doesn't get admitted. And so then they wind up back on the street and they wind up drinking. They can't go to rehab when they're acutely intoxicated. So this is a bit of a conundrum here. But if you can manage them well, hold them for 3 days, put them on the long-acting benzo, then you can get them through the DT window and into rehab candidacy. The risk factors here are people who get DTs almost have severe alcohol use disorder. So what you want to ask about is, do you have a history of withdrawal seizures, previous DTs, or any concurrent illness? Pneumonia, pancreatitis, trauma, all of that are alcohol secondary related causes. So that tells you how severe the drinking is, which raises their risk. DTs don't typically happen in casual drinkers. This is due to chronic, high volume physiologic dependence. So when I do an alcohol detox in the home, these are the things that I ask for that tell me if it's safe to do a home detox with the patient. And then the other thing to keep in mind is DTs are not subtle. You will see delirium with fluctuating attention and disorientation. This is not a clear linear psychosis. This is clouded consciousness, delirium, right? They have marked tremor and psychomotor agitation, and the autonomic instability is pronounced. Fever, tachycardia, hypertension, diaphoresis, all of the indicators on the Siwa scale that tell you they're in withdrawal. Hallucinations are typically visual or tactile, often insects or small animals. And if the patient says the bugs are crawling on me and they're diaphoretic, tachycardic, and confused, that's DTs until proven otherwise. Withdrawal seizures typically occur 6 to 48 hours after cessation and can precede the onset of DT. So if you see withdrawal seizure, buckle up because you're in the danger zone. This person needs some benzos and some long-acting benzos and need to wind up in the ICU. So management has to be aggressive and protocol driven. That's the backbone of the treatment here, and it's benzodiazepines. You can either do high dose symptom triggered protocols Or what I do, because it buys me time and it's a little safer, I front load the regimen. I give people up to 100 milligrams of Valium in the first 24 hours because the half-life is so long. And then if they kick me out by day 3, I know they'll have an auto taper on board. And if benzos aren't cutting it, then I have only done this about 3 times, where you switch to phenobarbital, used as an adjunct. The half-life is also quite long. The problem with that is a lot of pharmacies, it's so old they don't keep it. So I have to hunt around at that point. Many hospitals will use phenobarb because it comes IV and you can do it for severe cases. So you do have to support the physiology. Remember to give them thiamine before the glucose, replace the magnesium and potassium, and provide IV fluids, and that sort of thing. Antipsychotics are not first line here. These can lower seizure threshold and worsen outcomes, so keep that in mind. So remember, DTs are a lethal autonomic delirious state, not a psychiatric disorder. If you treat it like psychosis, instead, you're going to make this worse. All right, what about other substances? So other substances that may cause you to have symptoms that look like psychosis, sedative hypnotic withdrawal like benzodiazepines, barbiturates, even the Z drugs like Ambien and the like zolpidem. Sedative hypnotic withdrawal is essentially alcohol withdrawal in disguise, and they get a lot of overlapping symptoms like anxiety, tremor, autonomic instability, and the risk of seizure and delirium is still there. So this is not something you want to wait out. You need to manage this the same way you would manage with benzodiazepines or phenobarb, and then close monitoring and the like. The other one to note here is the synthetic cannabinoids, K2, spice, bath salts. These are chaos drugs. With these, you want to expect severe agitation, paranoia, frank psychosis, tachycardia, hyperthermia, essentially a toxic sympathomimetic state. So management here begins first with high-dose benzos and aggressive hydration and cooling, and then antipsychotics only if the psychosis persists after the agitation is controlled. These patients will go south very fast. The other ones are dissociatives like PCP and ketamine. So ketamine centers are popping up like med spas everywhere. And then there's a high street value, especially in my Asian young population. They use ketamine. The reason ketamine is popular, it doesn't show up on the random drug test. It's not in the standard point of care test. You have to specifically test for it. So that's why ketamine is gaining popularity, especially in cultures where it's high social stigma, or there's a high cost of penalty, say in Asia, where like there's the or death penalty for possession, essentially. You will find that people there, young adults, will use ketamine. So PCP and ketamine produce very recognizable symptoms. They are psychosis, nystagmus, and analgesia, and the potential for violent agitation. These patients often don't feel pain because we use these things for pain, so physical struggle becomes dangerous for everyone involved. The safest approach to these people is benzodiazepines, minimal stimulation, and avoidance of a hands-on confrontation. Also, you want to monitor these people for CK levels because that prolonged agitation can set the stage for rhabdomyolysis to develop. The pacing, the hand wringing, the twisting, the writhing, all of that. The other one that can cause symptoms that look like psychosis is opioid withdrawal. They're rare psychosis, but you should be aware. Opioid withdrawal often gets misclassified as psychotic, but it never is. What you're actually going to see are things like myalgias, lacrimation, yawning, piloerection, goosebumps, dilated pupils. Check out the COWS scale for those symptoms there. You'll see what we're talking about, an intense dysphoria, anxiety. This is a miserable state, and they may get desperate. They're not psychotic, though. And treatment is straightforward. Buprenorphine or methadone. Methadone clinic needs to do methadone, but buprenorphine is more readily available. I like Suboxone. It's combined. It reduces the risk of diversion. And plus symptomatic support. So antiemetics, Zofran fluids. Someone is psychotic in opioid withdrawal, you have to look for another cause, like intoxication with something else or polysubstance abuse or stimulant use. Cocaine and alcohol is popular together. Or underlying primary psychotic disorder. The thing to pay attention to here is in the withdrawal state, there's this altered perception, increased agitation, hallucination, substance related. They often will explain the picture. Your job is not to just identify the psychosis, but to identify and track the train so that you don't miss some life-threatening or underlying withdrawal syndrome. All right, so the medical mimics. Neurological conditions can cause things that look like psychosis, things like temporal lobe epilepsy. Will they report deja vu symptoms, olfactory hallucinations, or behavioral arrest? Just stop in midair. Brain tumors, traumatic brain injuries. They come with acute personality changes or paranoia or disinhibition. Dementias, especially Lewy bodies. These patients have prominent visual hallucinations. So if someone is having psychosis for the first time in old age, it's not a primary psychotic disorder. You need to think about these dementia and neurocognitive deficits. If the psychosis is visual, fluctuating, or paired with cognitive changes, your index of suspicion needs to jump right up. I won't say a lot about the autoimmune NMDAR encephalitis. This is huge, though, and becoming much more recognized. This is a psychiatric first, medical second illness. This is a young person, rapid onset, bizarre behavior, catatonia with autonomic instability. If they have autonomic instability, it's not schizophrenia until proven otherwise. So if you see psychosis, dyskinesia, seizures, unexplained autonomic swings, you need to test for this. I sent you the video in the content section. Watch that separately. You can read the article or dump it into the AI and have it summarized for you. Endocrine and metabolic disorders can also cause psychotic symptoms, things like thyrotoxicosis, Cushing's, hypoglycemia, uremia. So refer back to that third lecture of underlying psychiatric manifestations of underlying medical conditions. Infectious etiologies, toxic medications, those are the red flags that look for workup. So the red flags are fluctuating attention, new focal deficits, severe headache, atypical onsets, and autonomic instability. So I'll refer you back to lecture 3 and this. Anti-NMDA receptor. Did not expect that. Okay. So anytime a patient presents with possible psychosis, you first have to ask, is this psychiatric or is the brain in danger? It's the red flags that tell you when to stop, reassess, and reinitiate a workup. So you will do medical workup if there's acute onset with fluctuating attention, new focal or neurological signs. Focal deficits mean stroke, mass, seizure disorder, encephalitis. Atypical onset. The first episode psychosis before age 12 or after age 40, not normal. I would say if you're having psychosis before 18, frankly, not normal. And that's a medical workup every time. Late onset psychosis almost always has an underlying neurological condition, abnormal vital signs, autonomic instability, toxic issues, things like that. Those are the red flags that should prompt investigation and or referral. All right, let's talk about this brief psychotic disorder. So brief psychotic disorder, again, more than 1 day, less than 30 days, the patient must return to baseline. And you only need how many? One core psychotic symptom, either a delusion, a hallucination, a disorganized speech behavior. That's the presentation. And it's often stress related. Stress like what? Grief, trauma, acute crisis. The prognosis is usually excellent. This will rapidly resolve. That's the blessing. Schizophreniforms between brief psychotic and schizophrenia. Here, the duration is 1 to 6 months with symptoms that look identical to schizophrenia, but they don't have the functional decline. It's not required for this diagnosis. And the risk of progression is higher if you have a big prodrome as well. The bottom line is brief psychotic disorder resolves quickly, cleanly. Schizophreniform is that middle zone where time and early signs will tell you who is heading to schizophrenia. And then schizophrenia in and of itself has these 3 phases. So there's a prodromal phase. This is the slow burn. Think of this as the nervous system is whispering long before it screams at you. You're going to see things here like odd beliefs, ideas of reference, subtle perceptual disturbances, nothing dramatic to trigger an ER visit. And then what does show up is you'll start to see negative symptoms, avolition, social withdrawal, affective flattening, poor hygiene, dropping grades, missing work. The family will say things like he's not himself or she's fading. And this is where you will see a progressive functional decline. And this is where you need to test for drug use as well, because that trajectory is actually one of the strongest predictors of a long-term outcome. And then after some months, they may go into the active phase. And this is the phase that everyone tends to picture when they think of psychosis. This is the hallucinations, delusions, disorganized speech, disorganized behavior, and sometimes catatonia. This is the diagnostic anchor. This is the point where the illness becomes undeniable. This is where you're giving bad news to someone whose hopes and dreams were in the progress of their kid going to college and launching, and they're 19 years old, and you say, I'm sorry, they have schizophrenia, and that whole planned life trajectory is utterly derailed. What matters clinically is that the patients typically have a marked functional impairment, academic collapse, job loss, inability to care for themselves. This is the moment where early treatment can make the biggest difference. So hopefully they buy in and don't say you're a dingbat, you're not even a doctor, and I don't want to be treated by you, and I'm going to go diagnosis shopping, because then they delay care and the outcome is worse. So once the acute psychosis settles, we wind up in the residual phase. Patients don't return to baseline here. Negative symptoms take center stage in this phase. The apathy and the cognitive slowing and the impaired social functioning will persist. The positive symptoms may attenuate a bit, but they often recur during periods of stress or substance use or medication non-adherence. And this is where we do that quiet, steady work of rehabilitation. That coming back every week can be a point of stability for them, and it increases your sensitivity to their baseline. So when you think about schizophrenia, don't just think about the hallucinations in isolation. Don't forget the prodromal decline, the acute decompensation, and that residual new baseline, that new normal for them, because those phases may help you intervene earlier. So a little bit on the epidemiology here. So prevalence and onset. Schizophrenia has a lifetime prevalence. This is a board's question of about 1% worldwide across cultures, And typically the onset is young adulthood. But more importantly, it's not the same for men and women. Men typically have it between the ages of 18 and 25. Men tend to present early, and you'll often see more negative symptoms with poorer functional responses and higher hospitalization rates for men. Women, on the other hand, tend to present between 25 and 35, and they're more likely to show symptoms of dysphoria, anxiety, and paranoid delusions with fewer prodromal warnings. Schizophrenia is more common in males overall. You'll typically see it more commonly in firstborns or individuals from lower socioeconomic backgrounds. Now, I don't know if that's just because they're more likely to be diagnosed. And you'll also more likely see it in urban environments. I don't know if that's because there's more psychiatrists in urban environments. All of which will reflect environmental stressor, access to care barriers, social determinants of health, and the like. The clinical relevance here is that these patterns are not just, nice to know. They help you stratify risk and guide some early detection and shape how you counsel families about prognosis. So a 19-year-old man with negative symptoms and functional decline sits in a very different risk category than, say, a 32-year-old woman presenting with a new paranoid delusion. So you want to use epidemiology as a clinical lens, not just to know nice statistics, because this is to help you understand who's at risk, who's deteriorating, whose trajectory you have the best chance of changing. So course and prognosis, because this is where the families want clarity, and this is the question you're going to be asked a lot. Schizophrenia follows a phasic trajectory. The prodromal phase, then the active phase, and finally the residual phase. Most patients move through the three phases, relapsing and remitting in a pattern, not in a straight line. So functional decline is almost always the precede to the first positive symptom. So when a student or a young adult or a new patient is losing academic or occupational footing, that's the early warning sign, even before hallucinations or delusions appear. The good news is that the early identification and early treatment can make a big difference. It can improve long-term outcomes and reduce chronic disability and slow the accumulation of negative symptoms and cognitive impairment, because those are the true drivers of the lifelong disability, not the hallucinations. The prognostic factors, this is the question you get asked a lot. The favorable indicators include what? Later age of onset, higher premorbid functioning, education, relationships, stable roles. Clear precipitant, so especially if a substance triggers it, where stabilization can happen quickly, and most importantly, a strong family and social support paired with early adherent treatment. Those are the things that are favorable prognostics. The poor prognostic indicators are early onset, especially males, prominent negative symptoms with cognitive deficits, and substance use disorder chronically being done. Also, that tends to come with low supports and a pattern of repeated hospitalization. So when you put all that together, you get that framework that helps you counsel families and anticipate risk and design treatment plans that can match the trajectory of the illness, not just the symptoms of the day. So let's take a look at a case here to anchor all this with a real world situation. 22-year-old college student coming into the outpatient clinic, and his main concerns are the voices are commenting on his actions and ideas of reference, particularly on campus. This already is telling you we're squarely in positive symptom territory. But what really matters is this course. He had about 8 months of functional decline here. You see poor grades, social withdrawal, increasing isolation. This is the timeline that's classic. So biologically, he's safe. There's no suicidal or homicidal ideations, but he's sleeping 4 to 5 hours a night. The appetite is down, the energy is low. So all of this fits that blend of the prodromal deterioration, plus now you have emerging active phase symptoms. So his history supports a primary schizophrenia pathway, right? There's no substance use for over a year. Urine drug screen is negative. No neurological red flags, no seizures, no endocrine, no recent head injury. He has a maternal uncle with schizophrenia, which does increase his vulnerability. And then take a look at the mental status exam on the right side there. So he's disheveled, avoids eye contact, seems internally preoccupied, speech is sparse, and the affect is blunted. Thought process shows loose associations and tangentiality. The thought content includes persecutory delusions and ideas of reference. There's perception, which has intermittent auditory hallucinations that comment on his actions, and his insight is limited. So this pattern is extremely consistent with early schizophrenia in young adults. So here's now where we bring in the RDoC framework because it helps you structure a care plan. So first, you have these positive valence where he has anhedonia, avolition, and a signaling reward system dysfunction. So here, you want to target behavioral activation with structured daily routines. Second, you've got cognitive symptoms, system involvement. So he's showing a working memory and executive control deficits. That leads us towards cognitive remediation, supported education, and executive function coaching. You don't necessarily have to have this person drop out of school if he can get the support there. Also, if he can get mental health care that way. If you do college health, you're going to be encountering the prime age of schizophrenia. Third, you've got social processes. So this theory of mind and perception of social cues are impaired. So he needs social skills training. The family's going to need some psychoeducation and some predictable interpersonal environment. So group therapy could be useful here, or a psychosocial clubhouse, or ongoing support groups, or admission. Arousal and regulatory systems are disordered, so his sleep is disrupted, and that will worsen symptoms. So you definitely want to target sleep hygiene, consistent wake times. Even if he doesn't have class at 8 o'clock in the morning, you want to get him up and out so he can be exposed to daylight. And you want to stabilize that daily schedule. So what I want you to take out of this is how the RDoC lens turns this scattered presentation into a treatment roadmap. This will ground psychosis care in the circuits and functions, not just labels. So I don't want to spend too much time on this because you're going to have a whole psychopharm lecture, but the highest levels, all antipsychotics share this core action of D2 receptor blockade. And most second generation agents will also block 5-HT2A, and this is why they tend to lower EPS and have a higher metabolic burden risk because they stimulate appetite. And then there are some, nuances among them, but suffice it to say, they're all working on the dopamine pathways And we'll get into that more so in psychopharmacology. All right, so let's pull this treatment back now and look at the RDoc lens here again. So the cognitive systems, this is where you target things like attention, working memory, and cognitive control. Um, Cognitive remediation, errorless learning, supported education or employment. These things tend to help patients generalize their gains from acute care into real life. This isn't a theory. These interventions do improve functional outcomes, but they take some time and they're hard to access sometimes. But that kind of helps you guide where to find them. The social process, this is the theory of mind. This is where you teach things like social skills training, structured role play, drama therapy, targeted feedback, and family psychoeducation. Multifamily groups can teach both the patient and their support system how to communicate and regulate conflict and prevent relapse and avoid hospitalization if we can. The positive valence system, this is the domain about reward. So this is where you're targeting the negative symptoms, the anhedonia, the avolition, the why bother energy. And the interventions here include things like behavioral activation. I don't feel like doing it. Do it anyway and see if the feeling comes. I think of this. I don't feel like working out. Go to the gym anyway. Once you start going, then the motivation will come. This is where you'll do things like motivational interviewing and contingency planning. This is how you rebuild that reward learning and get the momentum back. Eventually, your feeler will catch up with your doer. Negative valence, this is where we want to reduce that threat reactivity and stabilize their physiology. So this is where trauma-informed care, anxiety management skills, and CBT for insomnia are a major player. So regular routines, predictable schedules, environmental stability, all of that becomes part of your toolkit. Sensory motor systems, this is where the motor circuits where EPS, catatonia, tardive dyskinesia are. So active EPS monitoring here is where you're, especially if you're going to be on multiple antipsychotics. Don't forget to utilize PT and OT to encourage mobilization. That can be useful. It's also another person's contact. So when you map those interventions to the RDoc domains, your treatment can be very targeted and you can have a roadmap. Non-pharmacologic treatments, we've talked about CBT for psychosis. The goal here is not to argue with the delusions, it's to help them reality test more and reduce the conviction and reduce the distress tied to the voices or the intrusive thoughts. Relief often comes from reframing the meaning of the symptom, not eliminating it. Also, family psychoed support. You want to lower expressed emotions because people will yell and curse out of frustration. You want to help meaning. You want to help them create meaning to reduce criticism and hostility and over involvement because that will cut relapse risk almost in half. And we want to teach families about relapse prevention plans, safety plans, medication strategies. You want everyone rowing in the same direction. So I know that's idealistic and the chaotic families abound. Social and functional interventions. So skills training is critical, especially for patients with disorganized behaviors or social withdrawal. Supported employment and education, vocational rehab is a big one. Um, and then the message here is essentially you don't want to wait for symptoms to resolve completely before you restore function. But at the same time, you don't want to sabotage the program you're sending them to, because if they act up too much, then the program may not want them back. So that's the fine line you're walking. Cognitive remediation, this thing will target attention and working memory and executive function. The key is to pair a cognitive exercise with a real world practice like academic coaching or job training. That's going to directly improve long-term function. And then the circadian rhythm, you want to normalize that sleep, get some daylight exposure, light box, schedule activities, keep a rhythm. You can even do that with your failure to launch people that look prodromal. That's useful as well. And then integrating substance use disorder care, because this is often co-occurring. So when substance use is on board, you want to integrate motivational interviewing and contingency management, maybe Vivitrol injection, depending on the substance. These programs will help reduce relapse and hospitalization. So these interventions can't be secondary. They all have to be a both and approach. So the main thing you want to remember with psychosis is this algorithm of safety first. Always step one, stabilize suicidality and homicidality, agitation, delirium, anything that threatens life or prevents an adequate assessment, you need to deal with first. Step two, mental status exam and collateral. Psychosis rarely is diagnosed accurately in isolation, so you want to get records, family, roommates, campus security, EMS. You want to fill in that timeline because the patient might not be able to. Always rule out mimics. Please don't miss them, including substance-induced and withdrawal states and deliriums, and especially in atypical presentations. And then don't forget to quantify with duration the psychosis you're contending with, 1 month up to 6 months and more than 6 months. And don't forget to look at mood symptoms because this could be psychosis due to mood. If there is more than 2 weeks of psychosis in the absence of mood symptoms, then you're moving away from bipolar depression towards schizoaffective or schizophrenia. So that's a good way to do that. And then anything atypical, you have to verify, especially if it looks like malingering. So use some structured tools, do it with curiosity, and don't forget about neuropsych testing if you can to clarify the diagnosis. And of course, you want to map your interventions to the RDoc domain at play so you can do a both and. You have a neurobiological theory to underpin both your medication and psychosocial interventions. So if you follow these steps, you're going to create this safety structure, medical clarity, duration, mood, verification, etc. You're not just diagnosing the psychosis accurately, you're being very responsible in your approach, which because these are sticky and hard to undo. So negative symptoms are the ones that drive disability. So don't get distracted by the hallucinations. Don't forget to focus on them with the psychosocial interventions. Real auditory hallucinations are supposed to fluctuate. Genuine auditory hallucinations are intermittent. They're not constant theater. They're often critical or commentary, not just commands. And the command hallucinations, only about a third of them are acted upon. So assess the intent and the historical behavior, not just the content. Visual hallucinations, think medical first. If someone is seeing spiders and shadows and geometrics, think delirium, substance withdrawal, or neurological causes. And remember to reassess orientation and look for that fluctuating attention span. Duration plus impairment is what equals the diagnosis. So brief psychosis is under a month, schizophreniform up to 6, schizophrenia over 6, but only if there is functional impairment. Never forget the schizoaffective rule. You need 2 weeks of psychosis without mood symptoms to move away from bipolar or depression. And if it doesn't fit, verify. When the story feels inconsistent or exaggerated or medically improbable, slow down, run the 6-step malingering workflow, pick a validated tool, consider neuropsych testing, and don't forget to map them to the RDoc so that you can tie in the mental status exam and provide good psychosocial care as well. So hopefully this keeps you accurate and on track. All right. Finally, safety first. Anchor yourself in the mental status exam plus collateral. Build a structured differential. Remember to formulate using the 4 Ps so we can figure out context, not just a checklist, and verify when something doesn't fit. And remember to monitor over time. Well done on your stamina.